All right. Now we're going to do a quick refresher on termination of resuscitation now. I would like our EMTs and AMTs to also um, listen to this and pay attention because there's going to be some shared decision making, and you are a fail-safe measure or some redundancy to help your partners in making these decisions because it's a heavy cognitive load to make this decision, especially if you're the only one doing it. And it's much more reassuring if you can look to your peers and your partners and say, here's what I think, here's my plan. Do you agree? So I think when we initially initiated um, termination of resuscitation, it was somewhat controversial. We were concerned what the family might think, but I think now there's almost universal buy-in on this. We haven't had any issues. Um, I think the only issue that we might have had is when we terminated and then a patient regained a pulse, but then they quickly realize, oh, the patient has a pulse. We have to switch gears, um, and then the patient lost a pulse, and then they decided upon transport. And I think that's probably the best thing to do. If you're 20 minutes in, the patient meets all the criteria, and then you terminate, and they're in asystole, and then you see some spurious beats, and then it gets faster, and then the patient regains pulse. At that moment, we should probably just transport. But um, the goal in this protocol is to, one, for our safety, prevent the unnecessary and unsafe transport of those patients who are unlikely to survive to begin with, and also to help the family in the grieving process because what we used to do was we would start CPR, do a few things, load the patient on the stretcher, put in the ambulance, and go to the hospital. Then the family would arrive at the hospital, and the physician or someone would say, I'm sorry, they're dead. And they're going to say, what do you mean they're dead? I just saw them doing all these things, and they didn't say anything. And so this really helps the grieving process. So we want to, when we're terminating, prognosticate what are the chances of this person surviving, and is further resuscitative efforts going to be futile? All right, can we prognosticate the chance of this patient having a meaningful survival? All right, then we want to prevent determination of the lucky survivors, those who imagine this. So a person's chance of surviving at the 20-minute mark, you can assign a certain percentage to it, right? And I'm going to arbitrarily throw a number out there. Let's say less than 1% chance, all right, at 20 minutes if you don't get a pulse back. I'm sure there's a number out there. As we go longer, let's say at the 30-minute mark, that person's chance of surviving, if they have not regained a pulse at that point, then goes down to 0.0 something. All right, so the longer that we go, that person's chance of being one of those lucky survivor goes down. Now we can also throw in physiological parameters. So let's say we've resuscitated them for 20 minutes, but also their end tidal with good CPR is less than 20. So then that person who was at the 1% mark then goes down to 0.0 something at 20 minutes. We can even extrapolate on that even further and say, okay, if this person was not found in a shockable rhythm or was found in asystole or agonal PEA, has a low end tidal, did not get bystander CPR, then we're further prognosticating that person. So who does this not apply to? The patient has to be at least 18 years of age. I'm sure that will change eventually. But right now, for various reasons, it's remaining at least 18 years of age. We want to consider resuscitating if the person has a medical condition that might have a better outcome despite prolonged resuscitation. So, generally, it's someone who's suffered from hypothermia, maybe even hyperkalemia might fall into that. If we can just do something else, if we can get their potassium down, if we can warm them up, which is going to take longer time than 20 minutes, it does not apply to those patients. So the NAEMSP has, the National Association of EMS Physicians, has came out with a position statement on this, and that's kind of what the basis for this guidance is. And then there's also some studies that we've referenced that helped us develop this protocol, and then just some common sense. So, what rhythms can we terminate? I know there was some confusion because our protocol used to include termination of resuscitation if the patient's in refractory ventricular fibrillation. We had to work them a really long time. That is no longer the case. We cannot terminate that rhythm. All right. And it is refractory or recurrent ventricular fibrillation. So if you get there, they're in VFib, you shock them, they're in asystole, and then they remain in that for the duration of your care, then that's not included in that. However, we can't cover every possible situation, every possible rhythm change. So if the patient is presenting in rhythms that are not well defined in this protocol, then you should contact Online Med Control. So, what rhythms can be terminated asystole? Well, the state medical advisor and some other folks actually define agonal, wide agonal, very slow complexes as a variant of asystole. And I've had a lot of talks with him on this. So, our protocol, which we're going to look at, is if the PA, I believe, is greater than 40, or if they're in ventricular fibrillation, we do not terminate. So some people arbitrarily define agonal beats as anything that's wide and less than a rate of 40, although that is somewhat arbitrarily defined. But generally, if you get the occasional spurious complex, then that is definitely included as a variant of asystole. So our protocol is asystole if there's no ROSC after 20 minutes in the absence of hypothermia. All right. And then the other portion of that protocol is if it's an aerocomplex PEA greater than 40 or refractory and recurrent VFib VTAC, we do not terminate those. And you're going to have another training on pre-hospital ECMO activation, and most of the time those patients would follow under that protocol. They meet that criteria, so we'd be transporting them anyway. Now, something I will note is that in order to maintain good brain perfusion, good neurological perfusion during transport, we need mechanical CPR. And additionally, it is unsafe to transport these patients without mechanical CPR. And you'll see it listed in the protocol. If mechanical CPR is unavailable, then doing CPR during transport imposes an undue risk, and then we should consult Online Med Control and hopefully work that patient longer until either they devolve into asystole with a low end tidal, or we get a pulse back. Now, just because we meet this criteria, so this is just a rhythm, all right, and a minimum time on scene, all right. now we have to go into the physiological criteria to make sure to prognosticate this patient. Say, what is this person's chance of surviving physiologically? Like, do they have any evidence of good neurological function? Do they still have good perfusion? Are they still producing, CO2 as a byproduct of metabolism? All right. And we also want to confirm that they are in fact dead. So, in addition to the 20 minutes of resuscitation, they can't have vital signs, right? No spontaneous pulse, no respirations, all of those things. No evidence of neurological function, meaning even if they're in asystole and we're doing CPR on this person and they have an occasional gasp. You remember in that video that was played earlier, the paramedic told the family member that gasping was a sign of death. It's just air escaping from the body. Well, it's also a very favorable prognosticating indicator that this person is trying to live. So if they're gasping, if they're lacrimating, if they're swallowing, if they're moving while you're doing CPR, do not terminate that person. That is evidence of neurological function. All right. They can't have a pulsatile SpO2 pleth. So I want to not only place the SpO2 probe on the finger, but I want to see the pleth. And now, some people might think that we're trying to measure the SpO2 during cardiac arrest. That is not true. We're just looking for a pulsatile pleth. This achieves a few things during CPR. If we're doing 30 to 2, and we're giving those 2 breaths, and we see during the 2 breaths, if we see SpO2 pleth, we're going to think, oh, this person must have a pulsatile. They have a pulsatile waveform, and that requires the heart contracting to send those pulses to the extremities. But also, if we're terminating and then they have a P8 rate of 20 or 15 or something like that, and then we see pulsatility on the SpO2 pleth, then we should reevaluate and think maybe this person's heart is actually beating. It's just really slow. And it's not strong enough to produce a palpable pulse. We implemented this in our protocol after I heard a case about paramedics terminating a patient with slow PA, but they had the SpO2 probe on the finger, and then when they did a post-event review, they saw after they terminating there were organized beats and also a corresponding SpO2 pleth. So they terminated someone with a pulse. Inadvertently, of course. And then the end tidal CO2 has to be less than 20. That number is somewhat arbitrary, and it's probably more important that the SpO2 is falling rather than, less than 20. If it's climbing, but it's at 20, that's actually more favorable. That's a favorable indicator. But if it's dropping with good CPR. Now, bad CPR is going to cause your end tidal to be low, all right? So you can have an end tidal CO2 of 15 because whoever's doing CPR isn't doing good CPR. So make sure whoever's on the chest is providing good quality CPR. Now, just to quickly cover this, you'll also see that in the protocol there is criteria for blunt traumatic arrest, and this will require a paramedic because you have to put the leads on and be able to interpret asystole. Although I know almost anyone can interpret asystole, but because of the scope and so on and so forth, it's got to be a paramedic. So if the patient's 18 years of age and you get on scene and it's blunt trauma and the patient is not breathing, pulseless, and asystolic, you can terminate and withhold resuscitation. Now, if it's a low speed impact and the patient has no outward signs of any injuries, then I'm likely going to initiate resuscitation on that person because it could have been a medical cause for them to wreck their vehicle or fall from a roof or whatever. So I do want to talk about how long we should stay on scene a little bit. There's a few different studies that are somewhat conflicting because the first one by Bonin et al., it was an older study in 1993. Now, an older study meaning that the CPR quality was probably good for what the standard was at the time, but the standard has improved. But they included 370 patients. If the person was going to achieve ROSC, they did so within 25 minutes. All right, so ours is 20 minutes, so that kind of lets you know that maybe ours is a little too low, but I like the 20 minutes because it is the minimum, and it doesn't mean that you can't go longer, because 20 minutes would be good for someone who's has other things present, meaning that they have some skin modeling, not quite lividity. It wasn't witnessed. No bystander CPR was provided, but they don't meet that criteria for you to withhold resuscitation. So we're thinking, all right, we're going to work them for 20 minutes. See if we get an output back. If not, then we're going to terminate. Some research that Wake County EMS has provided, and they had quite a few more patients. The duration of the resuscitation, all right, for 90% of their neurologically intact survivors was less than 40%. So, meaning if you resuscitate less 40 minutes, if you resuscitate at least up to 40 minutes, if you resuscitate at least 40 minutes, you're going to capture 90% of the patients that can survive neurologically intact. Now, there are cases where patients are resuscitated for an hour and they're discharged neurologically intact. Now, obviously, it's a very small percentage, but do we want to withhold or terminate resuscitation on someone who can possibly survive? The answer obviously is no, we don't want to terminate that person. We want to go a little bit longer. So you can go a little bit longer. Now, I think our protocol will capture those who are more likely to survive with longer resuscitation, meaning they have a shockable rhythm, the end title's favorable, they have some signs of life. Those are generally the ones that survive with the longer resuscitation. But there was this study called the OPALS study that showed that if the arrest was not witnessed, there was no shock delivered, no return of spontaneous circulation, it was not witnessed by a bystander, and the patient had no bystander CPR, then that would capture virtually all patients. All right, so consider that when you're deciding, should I terminate at the 20-minute mark or should I go longer? If the patient, even if they're in asystole or they're in slow PEA, should we go a little bit longer? This is just additional information for you to use when making the decision to withhold it or to terminate at 20 minutes versus 25 versus 30, right? So if I'm resuscitating a patient who has a good, compelling story, witnessed early bystander CPR, I'm going to want to work that person a little bit longer, regardless of if the protocol says I can terminate at 20 minutes. I'm likely going to want to go longer if there's a compelling story. Now, everyone is worried, and rightfully so, about the Lazarus phenomenon, which is if we resuscitate a patient and we stop CPR, And then we call the coroner. What happens if that patient regains a pulse and regains a rhythm, an organized rhythm with a corresponding pulse minutes later? All right. Now, this is pretty rare. I'm sure there are more than 60 cases in the literature, quite a few more. So there's at least 60, but there's probably more. Because people are afraid of the repercussions of this. If they say, yeah, we did CPR on this patient, we stopped, we called it, we marked the time of death, and then spontaneously this person woke up or regained a pulse. Now, there are some proposed mechanisms. Nobody knows exactly why. It could be if there's a low perfusion state, we administer a lot of drugs. Those drugs then take time to work because there's delayed action. But a mechanism that I'm interested in and I think is very plausible is the concept of dynamic hyperinflation. Think if we have a patient that is asthmatic, has COPD, or maybe even we just have high PEEP. This is why I am that's why I harp a lot on you to check your PEEP valve. That's why when you do your daily check, we preload it. That adds a lot of benefit. But if you incorrectly turn the PEEP down, thinking that if you crank it all the way down, that it's going to go lower and then backing it out, it's kind of the inverse of how you think a PEEP valve should work. If you're just looking at it and you think, down is lower, up, so backing it out, left is higher, then you could inadvertently turn the PEEP too high. But anyway, so this concept of dynamic hyperinflation, where if we rhythmically squeeze the BVM, which we're really good at not doing, we rhythmically squeeze that, we're breath stacking, causing the lungs to be hyperinflated, right? And then we decrease venous return. So by all metrics, all physiological parameters, it appears this person has those favorable prognostic indicators that they are not going to survive this. The end tidal's dropping, which it's going to happen if blood can't get to the lungs, right? And then you stop CPR, you call it, and then the air escapes from the lungs, whether it gradually escapes if you leave the BVM attached or you disconnect it and the air comes out, then the patient regains a pulse. So very important to make sure that we're not hyperventilating, that the PEEP's not too high. Recommendation is to monitor that patient. Leave them on the monitor after you terminate them. There's nothing wrong with that. I like that for my own peace of mind. In fact, we terminated a patient that had very slow agonal beats, and I'm like, I really want these to go away, so I'm just going to leave them on the monitor for a few minutes. And sure enough, after a little bit of time, the patient went into asystole. So I was much more comfortable with that at that point. Okay. Now, what about the patient who has a DNR? What about the patient who has some indication that they would not want these resuscitative efforts? So if it's clear that the patient doesn't want it, well, our goal obviously is to honor the patient's wishes. And the best way for us to honor that without any issues is to, check for an EMS DNR or a MOST form. And just a quick, look at the Kentucky EMS DNR, you can see that this form can be valid if it is notarized or if in lieu of it being notarized, it can be witnessed by two people unrelated to the patient. Now, it's generally a bad look if you show up on scene, the family says, hey, we don't want you to do anything, I'm the surrogate, and then you say, okay, here's the form, You sign it, and then we'll sign it. That's generally a bad look, and it can appear, I think maybe incorrectly so, that you are trying to not do CPR on someone, which actually that's what you're trying to do if the patient doesn't want it. But it's just there's something, this seems a little off about it, and the state board has said that people have done that with ill intention before, so we want to try to avoid that. But however, if you have the patient's legal surrogate who is in charge of making decisions for that patient, and they say, listen, they have this terminal illness, terminal disease process, they wouldn't want this, we wouldn't want this, your best course of action is to contact Online Med Control. Now, we want these forms filled out, so would it be inappropriate if the person was discharged from hospice and you get called to, I don't know, help them from the car into the house, and you say, hey, do you have a Kentucky EMS-DNR? Would it be bad to get it signed then? No, that would actually be very appropriate. Now, obviously, on the back of the form, it has some more instructions and when it's applicable. And it says that the person who executed the DNR, that, it can be revoked orally, or if they destroy the form. There is currently some debate as to whether if a person signs that, if a patient signs that, and they're in the right state of mind and they get it notarized, if it was a valid form, then there's some concern that that wouldn't be true, that they can't revoke it, or that the family couldn't revoke it on their behalf if the patient signed it when they're in their right state of mind. Anyway, that's currently how the form reads. Now, another form you should be familiar with is the MOST form, the Medical Orders for Scope of Treatment. Now, when determining what resuscitative measures you're going to provide, Section A and Section B is where you want to look. I do recommend, this is a busy form, there's a lot to it. I do recommend taking some time, hit pause, look over the different sections. But otherwise, if the patient is not in cardiac arrest, then the other sections are applicable. They dictate the patient would want fluids, antibiotics, and it's important to remember that this form is a medical order. It's not something that anybody can sign like the Kentucky EMS-DNR. So I think that both forms are useful. The form has changed. Now it can be there can be a digital version. I think hospitals are still trying to figure out how to navigate that situation and how to get it digitally out there. And the form, if you look on the back of it, there has to be an annual review if certain stipulations apply, if certain conditions are met. So there are sections for 2 reviews on the back of that form. So in summary, when in doubt, initiate resuscitation. All right, when in doubt, just initiate resuscitation. You must make contact with the patient and assess them regardless of what bystanders, fire department, or law enforcement say. You need to make contact. We went on a call for a patient that they thought was a crime scene, and law enforcement said, hey, they're dead. We want you to wait out here. I said, okay, and you confirm that you're telling me, do not confirm that this patient is dead. And he said, actually, you can come in, but just you. I'm like, okay, thanks. Now, this is in all but the most extreme circumstances, okay? Obviously, if the patient is 100 feet in a ravine and too dangerous for you to get there, and it's going to be hours before anybody can recover that person, there are very extenuating circumstances, but they are exceedingly rare. EMTs can withhold resuscitation based on futility or withholding with online med control orders and if the AED says no shock advised. Something I may not have mentioned, but if CPR is inappropriately started and EMS gets there and it shouldn't have been started in the first place, so the patient has no vital signs, they have obvious signs of death, you do not have to continue it. If you provide termination resuscitation on scene, continue monitoring the patient while waiting for the coroner to arrive. Now, I hope this answered some questions that you might have had. I hope that the information provided has been useful. And if you can think of any questions that I did not cover, then please let me know. Thanks.